Tina Lumper from Germany. So I'll share my screen. So we have 25 minutes, 30 minutes, and I have a lot of material, so I'll get underway. And it's my pleasure to present today about oral health. And okay, so we're going to talk about the normal development of the mouth, face, and important soft tissue anomalies. So the objectives I gave out were to understand the development of the dentitions, talk about childhood illness and its effect on the dentitions, and then how best to inculcate, introduce, include oral health in your pediatric work. So the laying down of dental matrix occurs approximately 7 weeks in utero. The calcification of the primary teeth, it's quite a different process, calcification, is 13 to 14 weeks in utero. And remember, the dentition is primarily ectodermal in origin. Now, the crown formation of all primary teeth is complete by age 12 months. Now, why we bother with this is because obviously illnesses and variations of good health affect the dentition. And later on, the changes in the dentition can be diagnostic, looking back at what happened. And for that reason, the primary teeth are seen as a fossil record of intrauterine development. The early studies on lead effect in pregnancy were done on the exfoliated primary teeth of children living in areas where lead smelters were, in northern South Australia, Whyalla, and in northern Sweden at the refinery there, lead refinery. So, and the arrival of the teeth happens at about 6 to 7 months of age. This is an example of the look of the primary dentition, the nice healthy gum pads, the frena here, and you can see the teeth busting to come through underneath there. These are 2 eruption cysts sitting over the lower incisors, and these teeth often are the first to appear at 6 to 7 months. Sometimes this causes pain and discomfort, but most often the teeth will come through. But if it does cause pain and discomfort, then a simple, very gentle, sterile needle into there and draining out a serous fluid will happen. Of course, I tell the parents that I'm going to cause the bub some discomfort. How they interpret that, who knows, in a little one, but it's going to be painful. But from experience, I know that trying to put topical anesthetic or anything on there is far more trouble given the taste of the topical anesthetic, and even putting local in is just not, is not conducive. This is a nice healthy primary dentition. And one of the important things is the arrival of the teeth. Now, a lot of people think that the teeth arrive in the order 1, 2, 3, 4, 5. In fact, the teeth arrive in the order 1, 2, the 4th one from the middle, back to the 3rd one from the middle, and then 5. So I've written that out as 1, 2, 4, 3, 5. There is an international numbering system for the dentition based on putting the mouth into quadrants. And most of the world use the WHO system of 2 numbers per quadrant, and defining the quadrants as starting on the upper right for adult teeth, 1, 2, 3, 4, going around the clock face, and then the primary dentition, the upper right is 5, and that's 6, and that's 7, that's the 8th quadrant. So the WHO system gives each tooth 2 numbers, the first number being the quadrant 5 or 6 or 7 or 8 in this case, because they're primary teeth. And then the second number tells you the position from the midline. So that's 7, that's 8, that's 5, 1, 6, 1, sorry, 5, 1, 5, 2, 5, 3. This would be the 7th quadrant. That'd be 7, 1, 7, 2, 7, 3, 4, 7, 5, and so on. The North Americans, particularly Americans, use a different system. Surprise, surprise. It's very important to have some idea of this, because unfortunately in forensics, you do need to often very carefully identify the dentition. This schema is meant to represent at birth, just to show you most of the primary dentition crowns are formed. And then within the first year, 6 months of age, 7 months of age, the upper and lower incisors come through, the primary teeth in blue, and the upper permanent teeth are just forming and the first permanent molar. So this is a crucial factor in problems with hyperplasia and hypermineralizing of first permanent teeth and upper anteriors that we're seeing all around the world, the so-called molar incisor hypermineralization effect. And I'll show you an example of this. So there's great interest in perinatal health, whether a lot of temperatures given with immunization, or did the lady late in pregnancy get antibiotics for urinary tract infection or something like that. There's a lot of work trying to identify why we've seen this incredible increase in developed and in developing countries of damaged first permanent molars and upper anterior teeth. So by age 2.5, 3, all the primary teeth are in place. And you can see quite a number of the permanent teeth are forming. This again just wants to show you how the permanent teeth are placed above the primary teeth. And you'd be surprised how many people don't appreciate this, that the 20 primary teeth, 5 in each quadrant, get replaced. But behind that, come once and once only, are the number 6, the 7, and then the wisdom tooth not shown on this schema. So you can imagine if you're caring for someone who unfortunately gets diagnosed with leukemia at this age, chemotherapy and or radiation, etc., that the dentition that's forming will be affected from there on. So the first permanent molars will be little affected. They're primarily mostly formed, whereas the bicuspid teeth and the second permanent molar will be damaged, and the roots of the anteriors will be damaged. And in the late effects clinic that we're involved in at the Westmead Children's Hospital, we spent a lot of time looking at the dentition of 8 or 9-year-old, 10-year-olds, because we feel that the developing dentition is a bellwether for children, particularly when quite young, when they've had a lot of input in their cancer care, that the permanent dentition can be a bellwether for the damage of other systems, from reproductive to cardiac to thyroid. And the clinician's always interested in what the dentition looks like, the permanent developing dentition looks like. That's why it's important to know just what's happening. For example, this is a primary second molar that came through about 2.5 years of age. It's missing a lot of enamel. The quantity of enamel is missing. It's hyperplastic. And this is associated with, in quite a number of case reports, with early issues with gut, particularly Crohn's disease. So recognizing hyperplasia of the primary teeth and knowing what they should look like can be helpful diagnostically. Remember, we had ectodermal tissue developing teeth. This is a child who will present to you with missing a lot of teeth, and it's classically ectodermal dysplasia. The lower incisors are missing, which is almost pathognomonic for ectodermal dysplasia. The salivary glands are not totally ectodermal, but the ropey, bubbly saliva is telling you that saliva is not working very well, not forming well, flowing well, and that's crucial for oral health. You must have saliva and adequate quantities of that. And there's missing teeth here, more conical teeth here. And you can imagine a child like this who might have had a febrile convulsion, and people put it down to a viral illness or something's gone on. And if they knew the dentition, they would say, hang on, this child is not sweating properly. They're not controlling their temperature. There's more going on here than we need to. They'll have other issues with such things as a lack of cilia and motility of cilia in the ear and in the ear and the nose and the throat, and have trouble with expectorating and getting rid of earwax and nasal discharge and so forth. See, this young guy has no eyebrows and eyelashes, and his fingernails have rarely grown at all. He's never had a haircut, of course. And I know when I look at his oro-facial area that he's missing a lot of teeth. His lower lip is everted because his lower gum pad is closed up to the upper gum pad, and the excess skin is everted, and his upper lip is rolled in and under because there's no upper teeth supporting it. Ectodermal dysplasia. So we can go from missing teeth to having extra teeth. And this is a midline supernumerary that's luckily erupted. And this little guy loved that tooth. I wanted to remove it, but he wanted it to stay there. It was a bit of dental bling. When you see one, you look for more. And supernumeraries are uncommon, but they happen regularly. It's important to know the arrival of the dentition. We talked before about the arrival dates, and this is someone who's 7 or 8 years of age. The lower incisors are through, the upper right incisors but not the upper left. When you see that, you know there's significant pathology here, and there should be a bilateral arrival of those permanent teeth and loss of the primary precursors. This is an example of a young lady with cleidocranial dysplasia, classic presentation of very delayed loss of primary dentition because of multiple supernumerary teeth, 40, 45, 48 I've seen, permanent teeth, crowding maxilla and mandible. Particular characteristic of the face is frontal bossing, hypotelorism, and a very delayed arrival of her permanent teeth, and the absent or hypoplastic clavicles. Another interesting variation of the arrival of dentition is a youngster with the asymmetric crying faces, where a depressor anguli oris is either absent or poorly innervated and not working well. And it affects the dentition in that the muscle is pushing across these teeth, and there's also a pacifier habit which is interrupted there, and it alters the occlusion. And the asymmetric crying face is interesting because of its association with other areas of medical interest, such as renal, particularly cardiac, maybe digital anomalies. And there's a very good summary of the issues around the asymmetric crying face from these people here. There's a slightly older person. I met this youngster when she was a baby, and the mother came and said to us, look, my daughter has a crooked cry when she cries. And here she is sometime years later with the classic appearance of the asymmetric crying face. Now, in line with this, we've talked about missing teeth and so forth. You'll notice here two beautiful permanent lower incisors, but what I really want you to notice is the upper central incisor. There's only one, half a left and half a right. This is the almost famous single median maxillary central incisor. And why is this important? Because of midline discrepancies, including hypophyseal defects and imperfect anus or undescended testis and umbilical hernia. But the classic is the hypophyseal defect and the great likelihood of growth hormone deficiency. So at 6 months of age, when you're all over the arrival of the dentition, which you should be, you can start anticipating and watching growth carefully in a youngster like this. And I don't think it will be noticed, because here's a person I met caring for their daughter, and we were able to point out to this person why they had enormous problems when they mentioned they were missing a tooth. And she'd actually, no one had ever diagnosed that she was missing an incisor and had lots and lots of midline discrepancy issues throughout her life, which was picked up at age 40. So it needs to be remembered. So interestingly, the single median maxillary incisors reported with asymmetric crying face not so long ago, and with other syndromes like Klinefelter's and Smith-Magenis. And it's a very interesting syndrome, and it's always one to tuck away to remember. We used to have that single upper maxillary incisor. Now the permanent teeth, again, now these are starting from birth. And again, to remember that the primary teeth are intrauterine fossil record, the permanent teeth are a postpartum record of intrauterine, of development. And the matrix is laid down third to fourth month in utero, but calcification begins at birth. And again, it's that perinatal calcification which can be affected by all sorts of ill health. Well, it's really important to have a perinatal history. And the teeth start appearing at 6 to 7 years of age, but the disconnect between the teeth forming at age birth and being done by 2 to 3 years of age, but not appearing for another 3 years, is often present when people don't realize the damage was done so early. So remember, the permanent teeth, when you see them, and they can come through, and I'll show you an example of the damage that can occur. This is a lovely, healthy, permanent dentition. You see the beautiful gingival tissues, the mucosa, and the gingival tissues here are absolutely crucial. We'll talk about those in a minute for the long-standing oral health of the individual. This is lovely permanent dentition. And they come up in the order a little bit different from the primary teeth. But first, the upper incisors and the first permanent molar, and then in between from the lowest 9 to 12, and then from 12 to 10 that way. The upper and lower canines come through quite a few years apart, which is quite unique. Now, this is an example of the hypomineralized, the quality defect that we're seeing in all countries, many countries around the world. These teeth come through at 6 years of age, and the referrals from everybody, medical practitioners, nursing practitioners, general dentists, and so forth, is that these teeth look brown and discolored, and they're usually exquisitely sensitive to temperature change. And there's often nothing to do but lose them, but yet they're very critical teeth in setting facial dimensions. So it's quite a problem to notice early. And if you have a child who's particularly unwell in the first couple of years of life, I'd love you to encourage establishing a dental home and anticipating these teeth to be looked at. Sometimes the dentition is affected by a genetic issue, and this is a dentinogenesis, where the teeth are this opalescent gray color, and these are crowns on the back to stop the teeth wearing rapidly. These teeth wear down absolutely quickly, and it's a real problem. But it doesn't always occur with osteogenesis imperfecta, but it can often. You must see the teeth as a bone with a marrow and covered in enamel, and keeping the marrow healthy is a big issue. And people talk about a nerve or a pulp. It's really a marrow, and it's much more understanding to call it a dental marrow. I want to go back to this slide again of a nice healthy dentition and stress the importance of the gingiva. The oral inflammation plays a major role in many chronic conditions, but it's ignored. The contribution to the body's inflammatory responses from the mouth is significant, particularly in infants and children, but also in adolescents and older people and adults. And it's crucial to recognize what healthy periodontal tissues is. And if I could get every medical practitioner to recognize oral health, the health of the gingival tissues, it would make a significant difference in public health. I call it the canary in the immunological coal mine. The periodontal tissues are such a window on the rest of the body. And let's have a look, for example, oral health is linked to global burdens in many areas. We know diabetic control is affected by poor periodontal health. Obesity is influenced, rheumatoid arthritis, cardiovascular disease, a lot of work on that. Imagine if you've had a renal transplant and your propensity for cardiovascular disease after that. You've just got to have really good oral health. And what renal transplant unit has a full-time oral health setup to maintain those patients? I doubt very few. I doubt very many, I mean, very few have them. Adverse pregnancy outcomes, and particularly more recently erectile dysfunction with long-standing periodontal disease. But one of the problems is, though, that the periodontium here looks healthy, but in fact it's been unhealthy for so long it's fibrosed, and the only way you can tell with radiographs is that there's been a loss of attachment here. This is much more obvious. So it's a difficult thing to do when you're not used to examining soft tissues. But I would love you to ask your people that you care for to have really thorough soft tissue dental examinations. This is a literally, I saw recently, 8-year-old girl. I was a bit suspicious of the color of her gingiva, and I just gently probed, and there was furious bleeding. She has a neutrophil function defect. The soft tissues are also very important. This was a presentation of inflammatory of oro-facial granulomatosis, and with a suggestion of other inflammatory bowel disease. And look at the difference in the gingival tissues. It should be very obvious when you become familiar with constantly assessing the soft tissues. The classic buccal folds of mucosa in that situation as well. I really want you to be looking in that mouth full time. Let's get on to the second part, and I'm going to have to fly through this a little bit, but some of the implications of childhood illness on the dental development. Now, one of the classics is the early loss of primary teeth. Where does that lead you? Well, first of all, the early loss of primary teeth is very much associated with primary immune deficiencies. I'm talking about 1-year-olds and 2-year-olds who lose teeth unnecessarily. This is an example of Papillon-Lefebvre syndrome, where there's a neutrophil function defect, an opsonization defect, And these youngsters, very young age, get adult severe periodontal disease, and lose their dentitions. Here's a child with presenting with a Langerhans cell histiocytosis at about 8 months of age. We've seen a number of these over the years. The classic cradle cap, nappy rash, the breaking of the skin behind the ears, and the floating of teeth on the OPG radiograph in a sea of nothingness. So that's a classic presentation of Langerhans cell. Here's another youngster at 8 months of age presenting with Langerhans cell. So really understanding the soft tissues, you can see why I call it the canary of the immunological mind. Cyclic neutropenia, another example of the importance of looking at the primary of the permanent, of the gingival tissues with early loss of primary teeth, cyclic neutropenia. Another example of early loss of primary teeth is hypophosphatasia and children presenting with this, and or odontohypophosphatasia, where just the dentition is lost. And it's not to do with the gingival tissues and immune response, it's to do with the nature of the root surface of the tooth and the bonding of the periodontal ligament from the tooth cementum on the root surface to the bone. Another example, scurvy. This youngster came through, and the first time I'd ever seen a child with scurvy a year or so back. And when we looked through the literature, there were numerous examples of children with special diets, usually with a special need, most often with a special needs background, and most often autism, with families following special diets or very different lifestyles. And this is a classic presentation of vitamin C deficiency. White bread and peanut butter was the main diet for this 4-year-old child. Another important factor in oral health is the prolonged bleeding from minor oral trauma. And this is a youngster presenting a week after falling at home and tearing their labial frenum and having a factor 9 deficiency that was previously unknown. Look at the gingival tissues here, so important to recognize, and healthy there and not there. This is an atriovenous malformation, which you don't want to lose. If those teeth come out by accident or loose, that's why the family came in. If that tooth comes out, this one particularly, then the child exsanguinates. It's just so important to recognize the oral structures. But more importantly, as you'll see from the following presenters, is children with special needs and the importance of recognizing their oral health needs. Prior to Willie, a child presenting like this, it's so disappointing to me. Someone who needs care, who presents way down the track as a 4 or 5-year-old with really bad oral health. It just is astounding. And this is an example of a child with osteopetrosis, dental caries, infection. He's only 2 or 3, and eventually it passes away with the effects of osteopetrosis. But this is equivalent to a bisphosphonate-related osteonecrosis of the jaws, where the infection from the teeth was unable to heal because of the osteopetrosis. Okay, dental caries. Look, we just can't go past it. It's a huge problem. And across all medical conditions, at least 2.4 billion people are affected. It's still the most common chronic childhood disease. It's hard to imagine how this is still happening. And the effect on sleep and school and growth and development. We're just coming up towards the end of our time, so I'm going to sneak forward to the very last. I'm going to leave a couple of little things there, and I want to come to the very last little bit here of how best to inculcate oral health into pediatric practice. Well, first of all, you got to see it. This is Batman. And as you know, Batman had a dental, nothing to do with Batman. This is 2 upper teeth and 4 lower teeth. You have to see it. And there it is, staring in the face every day, oral health. Oral health is a part of pediatric practice all day, every day. And it could come to you from the social justice gradient of disadvantage point of view. Children with oral health disease are usually a strong indicator of neglect, disadvantage, and or physical abuse sometimes. Mental health issues. Many children have poor oral health. chronic illnesses, and diabetes, and cerebral palsy, and everything else, and behavioral issues, children who damage themselves, who self-inflict dental damage, or won't open their jaw for 3 months because of abuse and psychological trauma, all need strong dental input, let alone diagnosing syndromes, 700 odd syndromes with pathognomonic. And of course, acute oro-facial presentations, from rings stuck on fingers or tongue stuck in drink bottles to physical and sexual abuse. So there's just so much relevance in putting oral health into your practice. I'm going to go to the end there and say thank you very much. And we pass on to Christina. Pretty soon is going to take over from me. Thank you for listening.
So, thank you so much. There's a question for you, Richard. There's a question.
Christina, you need to unmute your microphone.
I am unmuted. You don't hear me? Can you hear me? I am unmuted. Can you hear me? Hello?
Yes, I can, Christina.
Okay, perfect. There's a question to Richard asking, what are the dental requirements for children prior to organ transplantation? I think Richard cannot hear me.
That's okay, continue. We can come back to him.
Okay, so thank you for this great talk, Richard, and I will continue with another topic, which is MPSs, or mucopolysaccharidosis. And I hope I can share my screen now to show you my presentation. Actually, we have also some dental disease complications in mucopolysaccharidosis, like widespread teeth, the dental enamel defects, and the gingiva hyperplasia in our patients. And according to the series of webinars that we had in the past, I would like now to give you an idea how to differentiate the different types of MPS and how to follow them up, especially the patients that are attenuated or less severe affected. And just to give you an introduction again to the 7 types of mucopolysaccharidosis that are caused by the 11 enzyme deficiencies. So we are talking about storage diseases, or here storage of glycosaminoglycans in MPSs. And in order to make it a little bit more easy to make a diagnosis due to the appearance of the patients, I grouped the patients in the stiff ones, which means MPS 1, 2, 6, and 7. And in contrast to that, we have mucopolysaccharidosis that have hypermobile joints, like MPS 4A and B. So you see the difference. Actually, the stiff ones, it's very difficult to differentiate. And the MOCU patients actually are a little bit more different from the others. And then we have another group of MPSs for different MPSs, that is MPS 3, which have mainly a cognitive involvement, but also the appearance might be a little bit more different. So let's make a quiz, and I hope you will follow my talks and my suggestions, and to see what you think to these patients. So actually, I would like to know what type of MPS is this child. Ayla was 18 months when I saw her the first time. She is born from consanguineous Turkish parents. She has a healthy older and a healthy younger sister, now also a younger brother that is healthy. And she was born with normal height and weight, so on the 40th percentile of height. With 18 months, she was dropped down to the 10th percentile of her height and the 3rd percentile of her weight. And this is actually, with all the other signs and symptoms, why she was sent to a pediatrician for further diagnostics. So if you see the development or the neurology, you see that she was not able to walk freely, only standing with support at 18 months. She was not speaking, but understanding everything. Actually, she was also bilingual, so German and Turkish. And the muscle seems a little bit hypertoned. The reflexes were normal and the neurological exam normal as well. She showed an umbilical hernia, and the skeleton you could see, and I will show you some pictures of that, a thoracolumbar kyphosis, pectus carinatum, a hip dysplasia in the x-rays, but no joint stiffness that you would expect for the stiff MPS types. And in cardiology, she had a mild mitral and tricuspid insufficiency. Due to the ENT, we know she was snoring, she had already received an adenoidectomy, and she was suffering recurrent infections. She also had a craniosynostosis that I did not mention here, but you can see maybe on the head, which is not related to MPS, so it's something additional. And here's some more pictures of the child. You see the coarse face, you see the hip dysplasia, the narrowed spinal cord in the craniocervical junction. On the upper MRI pictures, you see in the spine, the thoracokyphoscoliosis, and also the dysostosis of the vertebrae. But now there was the question, which kind of MPS is it? First, it was a first step to understand this might be an MPS patient. And you see here this different examples for skeletal dysplasias, and you see that it is difficult to differentiate the MPSs from them, but she was as a suspicion of MPS SEND. So now here the history you can see again, but now which kind of MPS you would think she could be. And actually, let's say we start from here, I'm sorry. We start from here. She's actually probably a stiff one, but she has no really stiff contractures. So let's start with MPS 2. Is it possible that she is an MPS 2? So a Hunter syndrome. And actually, it is unlikely due to the fact that this child is a girl, and Hunter syndrome is the only type of MPS that is X chromosomal. So mainly boys are affected. There are a handful girls in the world, but these are spontaneous mutations, and usually the mothers are carrier, the boys are affected. And since she's a girl, Hunter syndrome is probably very unlikely. Let's go to the next type of MPS. Let's say MPS 3. As I said before, MPS 3, Sanfilippo syndrome, is mainly with a cognitive impairment or a cognitive involvement. So meaning loss of cognitive abilities over the time. And actually the face is not as coarse as in the other types. So actually MPS 3 is unlikely as well. So they have less clinical signs or physical signs at the beginning, MPS 3, but they have actually more cognitive decline over the time. And she has, for sure, she's not walking freely. She has some developmental delay, but she has also quite a lot of skeletal and cardiological involvement. So actually, probably MPS 3 is unlikely as well. How about MPS 4? As I said at the beginning, MPS 4 is the type of MPS that has hypermobile joints and no real developmental delay beside the gait, that is probably some waddling gait or some unsafe gait due to the hypermobility of the joints. But in her, she actually was has no hypermobility. She was not walking, but not because of hypermobile joints. And she has no cognitive involvement. So actually MPS 4A or B is unlikely as well. But how is it about MPS 6? Actually, MPS 6 have no cognitive involvement. So there are no types of MPS 6 with a cognitive involvement or cognitive decline over the time. The coarse face and the skeletal involvement and the cardiological involvement, also the ENT, is quite often in young children with MPS 6. So actually MPS 6 is quite likely in that patient. Next, MPS 6. Let's say MPS 7. How's about MPS 7? MPS 7, there's also treatment available since in some countries since a short time. So this is why it is important to exclude, even if it is extremely rare, much more rare than all the other MPSs that are already rare. And this child you see here, it is likely because she's fulfilling all the criteria. Actually, maybe one comment, MPS 7 is sometimes diagnosed as an hydrops fetalis in children. So if you have a child with hydrops fetalis, you should think to MPS 7 and sometimes also in MPS 4, but MPS 7 is quite often associated with hydrops fetalis. So next type of MPS, MPS 9. So why MPS 9 is unlikely? Actually, we have only around 5 cases described all over the world with MPS 9. So we don't know very much about that disease. And the diagnostics is more difficult than in the other MPS types. So actually they have more nodules on the joint. So it is more rheumatological. So MPS 9, let's say, is unlikely as well. So the last MPS type actually then is MPS 1, Hurler-Scheie and Hurler syndrome. And I will show you in the second part of my talk a Scheie patient in her from birth up to the 40 years of life. But in this child, indeed, she has a lot of signs and symptoms that could lead to the diagnosis of an MPS 1 syndrome. So let's say now, what do we have on our ranking? Which type of MPS it could be? It could be an MPS 1 for sure because of the musculoskeletal involvement and the coarse face. She could be an MPS 7. It's extremely rare, but we should exclude in any case because the symptoms are fitting. And it might be an MPS 6 patients because also here the symptoms are fitting as well. So actually what can we do? We know we have, and I started with that, 11 enzyme deficiencies leading to a glycosaminoglycan storage. Glycosaminoglycans are the components of the extracellular matrix. So this is why you have the storage everywhere in the body. And these 11 enzyme deficiencies are leading to 7 types of MPS. And if you see MPS 1, 2, 3, 4, 6, 7, and 9 have all different enzyme deficiencies and also different glycosaminoglycans or GAG storage. And this is actually the first step that you can do in these patients. You have different tests to diagnose MPS patients. The first, the screening test, which is not confirming the diagnosis, but the first you can do and the easiest you can do is measuring the urinary glycosaminoglycan excretion. So this is the first test. Unfortunately, in some MPS patients, especially if they are older, you have a normal GAG excretion, although the patient is suffering from MPS. But in younger children and more severe affected children, it's a good test to understand whether you have to make further diagnostics of MPS. But you cannot be sure that if the GAG analyzer or the GAG excretion is normal in urine, that you don't have an MPS patient. So, but it's a good and easy way to test, and you don't have to take blood. The next screening test, which is extremely sensitive, so you will not miss an MPS patient, but you might have false positive tests, is the dry blood spot testing. So you have a filter card, you take 4 drops of blood, and the enzyme activity will be measured. So then in the next step, the direct test, what you have to do to confirm diagnosis, and this is a little bit different from country to country if you use the genetic testing immediately or if you use the enzyme activity measurement in leukocytes of fibroblasts. In Europe, we mainly use as a gold standard the enzyme activity analysis in blood, but in other countries like US, also the molecular testing immediately is to confirm the diagnosis. So you have different ways: the urine, the dry blood spot, the enzyme activity testing in blood, and the genetic testing. Actually, now for the diagnosis, what we actually said already is that the child could suffer from different types of MPSs, like MPS 1, 6, and 7. And actually what we did is the first step, we did a urinary gag. And what we could see is that she was showing dermatan sulfate in urine. What we know is that only MPS 6 is only excreting dermatan sulfate, while MPS 1 should also have some heparan sulfate, and also MPS 7 should have some heparan sulfate in urine. Actually, the heparan sulfate is very important in the MPSs because it's the gag that is also leading to a cognitive involvement. So for example, in MPS 3, you have only heparan sulfate stored, and this is leading to the cognitive involvement. So in MPS 1, you have heparan sulfate, so it means it might be that cognitive involvement is present, but we have also MPS 1 patients that have, although storing heparan sulfate, no cognitive involvement. So it means heparan sulfate could lead to a cognitive involvement, but it doesn't mean that it is always like that. But if the patient is excreting only dermatan sulfate, MPS 1 and MPS 7 is actually unlikely. So we have to go to the next step, and we have to go for enzyme activity testing in blood here. We did not do the dry blood spot test, but we made the measurement immediately. And what we saw is an aryl sulfatase B deficiency, which is the enzyme for MPS 6. The MPS 1 and the MPS 7 enzyme were normal. They were tested as well as controls. And we did the genetics, and we saw a mutation, homozygous a mutation in the MPS 6 gene. So actually now, why it is so important immediately to differentiate between MPS 1 and MPS 6 or 7. And actually, we have enzyme replacement therapies for most of the types of MPS, beside MPS 3. But what we can do in MPS 1 is we have the chance for a bone marrow transplantation or stem cell transplantation if we perform it under the age of 2 or 2.5 years, meaning in the cognitive decline can be stopped if you make an early transplantation in these patients. And this is extremely important for the child. The sooner you do, the better is the outcome, because you stop this cognitive decline due to the heparan sulfate. So again, MPS 1 is the only type of MPS where you have the a stop of the cognitive decline if you perform stem cell or bone marrow transplantation under the age of 2 or 2.5 years. So this is important. And this is just to show you this child is an MPS 6. We have an enzyme replacement therapy available. You see her here at the age of 4.5 years. And you see that although she is growing, she is much better. Also, the coarse face is much better. You see she has some problems in walking and skeletal problem. And this is due to the fact that the enzyme is not reaching the bone or the skeletal system properly. This is due to the fact that the skeleton is not vascularized very much. Actually, Ayla has also a cousin in her family, and this is him. And he was actually born with an hydrops fetalis, which was tested as an MPS 7. They also then made a medical history and family history, and they understood that Ayla is suffering from MPS 6. They tested him immediately, and he was able to start the enzyme in the first few months of age. And actually, you see him here after some time, and he is much less affected than the cousin Ayla that I showed you before. But this is also due to the fact that he started the enzyme replacement therapy very early. So the earlier you start treatment, the better it is. From this case that I showed you, I want to show you now an MPS case, Kerstin. She is born in 1980, and it's a case of an attenuated or a Shire MPS 1 patient. And actually in 1980, there was no treatment available, just to remind that we have the enzyme for MPS 1 since 2001. So at this time, there was not very much awareness of MPSs. So just to remind you again, and as you saw also in the first case, Isla, MPS is a progressive disease and affecting almost all organ systems. And what we also always have to think about is the course phase. We have to think to corneal clouding, the hearing loss and the recurrent infections of the ears and the lung. We have the skeletal involvement with hip dysplasia, kyphosis and scoliosis, joint contractures, and also the neurological involvement in some patients storing heparan sulfate, or the other patients that are having no cognitive involvement. And these two girls that you see is one is a Hurler patient. You see the coarse face and the severe affected skeleton. And here it's on the other side with the pink trousers, it's an MPS 1 patient that you see almost no somatic signs and symptoms. And actually, this is the spectrum of disease severity that we have in MPS 1. We have the cognitive involved patients with severe physical signs up to no cognitive involvement in patients with quite a lot of physical signs, but starting later. So actually, this is the spectrum of the disease severity in these patients. And to show you that these patients need a multidisciplinary team taking care of them, even if they seem to be mild affected, I would like to show you Kerstin's history to see how things can be. So she is the first child of healthy non-consanguineous German parents. She has a brother born 1 year later, and he is affected as well, actually. And she has one sister that is 3 years younger, and she is healthy. The pregnancy and birth were uneventful. She was born spontaneously at 40 weeks of gestation, so nothing special. But actually, she was of low height and also low weight. Between 3 months and 3 years, she had an umbilical hernia repair. She had, at the age of 3 years, a motor developmental delay because she had problems in moving her shoulders. She had a mild kyphosis. She seemed to be a little bit hypotone. She had restrictions in the abduction of both hips and also contractures of shoulders, as I said. She was suffering recurrent infections of the airways and the ears. She was suffering diarrhea. She received a lot of physiotherapy because nobody was thinking to make any genetic testing or testing on a metabolic disease. But the development, the mental development was normal. And you see her here in the pictures, and she looks actually like a very healthy and happy child. So actually up to 1.5 years of age, she was seeing, due to the umbilical hernia, the surgeon and the anesthetist, she was, due to the contractures and the hips, seeing an orthopedics. She had, due to the recurrent infections and the ENT problems, the ENT physician that visited her, she had physiotherapy and the pediatrician checking her regularly. Between 3 years to 8 years of life, she was suffering again from recurrent infections of the airways. She was always smaller than the others, even if she looked absolutely healthy and normal, and other children were teasing her because she was so small. And by chance, at the age of 7, she had an accident and fractured her left leg, and she had to stay in hospital for 2 months. And you see her here, still looking absolutely healthy. And if you see the hands on the 6 years picture, you see that she had no contractures at this time, or not obvious contractures, let's say. So by this, up to this age, she was seeing also, due to the fracture of the leg, the radiologist and an orthopedic technician afterwards. Between 8 years and 16 years, actually, there was the first suspicion that something is wrong, because at the age of 10 years, she was suffering from stiffness and thickening of the fingers, and also in the brother. And this made especially the grandmother thinking that something is wrong, because they were playing cards or memory, and she was not able to turn around the cards in a proper way. She was too stiff. She was also not able to do some work with the fingers because of the thickening and of the joints and the fingers. And they went to a private practitioner. He said, maybe we should make an X-ray of the hands. They did it. There was nothing pathological in the X-ray, he said. And at 13 years, they and less mobility. They had physiotherapy without improvement. They started to think that something is wrong. And you see her here with 16 years, or here with 10 years. And you see here with 10 years, the fingers that are actually quite in a position of contractures. The family was very concerned about the two siblings, and what they did is they went to a university that was focused or was famous for skeletal dysplasias in Germany, and so they went there. The girl received a CT scan, electrophysiology, and they made the enzyme activity in blood for MPS and also the genetic testing. And even here, at the age of 14 years, you see that she has already contractures of the fingers, but that started at the age of 10 years, but nobody was thinking. So actually, she had even seen more colleagues, like here now, also the electrophysiologist and a geneticist that was taking care of her. Between 16, so when the diagnosis was made, up to 31 years of age, she was not followed by anyone due to the disease, because she was told when she was diagnosed in 1996, there's no treatment. She will have a progressive disease, which is true, but they also told her at the age of 35 years, she will be in a wheelchair, totally paralyzed, and she will not move anymore. So for her, the life was, or the end of life was at the age of 30 years. So she was very scared to have or to reach this age. And so she was not thinking to the disease anymore. She was not going to any assessments or to any visits, even if she had progressive stiffness of joints, especially while she was playing soccer in a team, and she was not able to manage anymore in a proper way. She had a body height of 1.45 meters, so she was much smaller than the others. And she suffered always from recurrent infections that took much longer to be healthy again as others. And she was suffering for quite a lot of pneumonia, and she needed glasses, but she was completely neglecting the disease due to the fact that she thought she had to die. She will die at the age of 30 years. So just to show you again, the first symptoms, the stiffness of joints, the shoulders and the hip dysplasia, and also the umbilical hernia, the recurrent infections, started in the first months of age, but they were not really understood because they are so unspecific, but they were not understood to be in MPS patients. There was no treatment available. As I said, when she was diagnosed, the patient was actually, due to that, not linked to a specialized center. She received only supportive treatment, but not preventive. So she had no regular follow-ups to be diagnosed in a proper way. She had no contact to patient organizations, and also the life-threatening and disease quality of life reducing disease complications that were progressive were not checked properly. But in 2011, the patient started to check the web. She started to collect information about the ERT. So here's just the time, 16 years. The diagnosis in 2001, the treatment was available, but she did not know. And at the age of 31 years, and she was still alive, she was checking about her disease, and she found that there are specialized centers. And as I said already, you have to check in MPSs all organ systems, the life-threatening like cardiac, respiratory, and CNS, but also the quality of life-reducing disease complications like the skeleton, the eyes, and the ears. So at the age of 31, when she started to be seen by a metabolic center, she was checked and she had the stiffness and contractures of joint and severe hip dysplasia. She had an aortic valve insufficiency, fourth degree. She had a craniocervical stenosis with no indication for surgery at that moment. She had a mild corneal clouding of the eyes and impaired visual acuity, and she had the lung involvement, and you saw that in the pulmonary function. So at the end, at this age, when she started to be seen by a center or a metabolic specialist, she had quite a lot of specialties that should visit her. In the next years, she started treatment, and actually she received a heart valve replacement and also craniocervical decompression surgery and carpal tunnel surgery. But what we see that she was actually quite stable over the years. She is a teacher in a kindergarten with babies and toddlers that she has to carry around. She is living alone, she needs no support, and she has a lot of physiotherapy. But as you see, even if she is a so-called attenuated patient, in a way, she has quite a lot of severe difficulties and complications of the disease, like the heart, the craniocervical junction. And here you see just the time frame and the pictures to understand what was going on. Early signs and symptoms. And actually in MPSs, the earliest signs and symptoms are extremely unspecific, recurrent infections, hernia, some stiffness, some developmental delay, and nothing really a specific symptom to lead to the diagnosis for MPS, but the combination, the combination of these symptoms may lead to a diagnosis. And you see how long it took until she was on treatment. And actually nowadays she's much better. And this is my conclusion. They have to start in planning and organizing the necessary assessments in your center for these patients. All organ systems must be checked. You have to discuss these results then in a multidisciplinary team to make the best recommendation to the patient. And actually then you discuss the results with the patient and plan the next steps, because not all interventions are good for these patients. So for this reason, you have to always balance the anesthesia risk. MPS patients have a high anesthesia risk with the benefit of a surgery like a hip replacement, for example. So my last conclusion is the treatment of MPS 1, and this is not only for MPS 1, but also for all MPSs where in which enzyme replacement therapy is available. You give the enzyme for sure, or you make the stem cell transplantations in MPS 1 patients if they are under the age of 2.5 years. But what it is extremely important in any case is, even if you don't have a treatment, it's a regular follow-up to detect the life-threatening and quality of life-reducing disease complications, and to prevent further damage, to plan surgeries, to plan medication, to plan orthosis and supportive therapy as you need, and to start that treatment. And actually this as early as possible, because it is a progressive disease, it is a storage disease. And whenever you have a patient with recurrent infections, hernia, and joint stiffness, think to MPS. And that's it. This was my talk. Thank you very much. I now would like to encourage you to listen to the 2 next videos that were part of the MPS webinars that was made in the last months. So good luck, have fun, and whenever you have questions, just contact me and I will answer your questions. Thank you very much. If there are any questions. No questions? Thank you very much.
Hello, everybody. Let's continue the series of cases. And today it will be short stature, and other endocrine presenting symptoms of mucopolysaccharidosis. It's a case study. But first of all, there are some housekeeping. And please do not take any screenshots. Submit your questions at any point via the question panel. Questions can only be submitted via text and not verbally. Here is my disclosures. And the case is part of this paper, short stature as a presenting symptom of attenuated mucopolysaccharidosis type 1, case report and clinical insights. We are going to talk about it. I have a short introduction. MPS I is an autosomal recessive rare disease caused by deficiency of alpha-L iduronidase and a lysosomal enzyme that metabolizes the glycosaminoglycans, GAGs, dermatan, and heparan sulfate. MPS I has an estimated incidence of 1 in 100,000 live births with a spectrum of phenotypes that range from severe, the Hurler syndrome, to attenuated Hurler-Shey, that is intermediate phenotype, and the Shey syndromes. Disease depending on neurocognitive involvement and the rate of disease progression. In the area of inborn errors of metabolism, that is my field of work, mainly lysosomal storage disorders, the earlier the disease manifests, the more severe is the enzyme deficiency. In the Hurler phenotype, the signs and symptoms will appear in the first months of life, very early, and the attenuated can be late, like 5 years old. It's a little bit far. The amount of enzyme residual activity will determine attenuated phenotypes, the Hurler-Shey, which is intermediate between the most severe and the most attenuated form, and the Shey phenotype. Here we can see the variability of MPS I expression between severe and attenuated phenotypes. The severe with a face infiltrated by accumulation of gags, thick and dry hair, bifrontal narrowing, thick lips, and the macroglossia. In the intermediate phenotypes, Hurler-Shey, the facial finds are milder when you compare with the severe one, but still have the appearance of MPS. And in the more attenuated phenotype, Shey can be very discrete and close to normal. Okay, treatment options include enzyme replacement therapy with hyaluronidase, recombinant human EDUA, and aldorazyme for patients with attenuated MPS I, and hematopoietic stem cell transplantation with or without hyaluronidase for patients with severe. The severe cases of MPS I, while the patient waiting for the HSCT should receive ERT in the majority of consensus, everybody agree with this, should receive ERT for the patients to be in better condition for transplantation. Treatment outcomes depend on the phenotype and the age of treatment initiation. Early treatment prior to irreversible damage can delay, stabilize, or prevent organic dysfunction, and is associated with substantially improved patient outcomes. Unfortunately, is an important delay in the diagnosis of MPS I, as you are going to see in this case, especially for patients with attenuated disease. In a study of natural history of 18 MPS I patients, 13 of whom had attenuated disease, whose symptoms were noted at 18 months. The mean age at biochemical diagnosis was 75 months. It's really a big delay. Male patients with history, now we are going to start the case presentation. It's a male patient with history of upper airway infections. It started at 3 months with otitis media, with a frequency of 5 episodes per year. Underwent ventilation tubes insertion at 5 years and 8 months, adenoidectomy with 4 years of age, and during childhood was hospitalized multiple times between 5 and 7 years of age for wheezing. He began experiencing hip pain at 5 years of age and was diagnosed with bilateral leg calve Pertz by an orthopedic surgeon. Okay. Patient was first evaluated by a pediatric endocrinologist clinic at 7 years of age due to his short stature and was treated with leuprolide acetate 3.75 milligrams per month between ages of 13 and 16 years. Recombinant human growth hormone, the GH, although the patient was not labeled as growth hormone deficiency between 14 and 18 years of age. And the patient presented sleep apnea through his teenagers, and at 7 years and 9 months of age was referred to a metabolic disease center, that it's my center, by a pulmonologist who evaluated the patient and suspect of MPS. These pulmonologists that take care about all our patients of mucopolysaccharidosis, that it's around 45 patients, and he takes care about these patients. When they saw the patients, he thinks about MPS. Upon examination in my center, the patient was found to have moderate joint contractures, mild facial coarsening features, scoliosis, umbilical hernia, and hepatosplenomegaly, and the heart murmur. His height was 154 centimeters, Z-score of minus 2.94, weight was 43.7 kilos, and head circumference was 56.5. Alpha hydrogenase activity on dried blood spots was 0.62 micromole per liter and per hour. Reference range between 2.5 to 16.7. Urinary gags, 5.6 milligram gag mole creatinine, and the reference range was 15 to 20 years, less than 4.9, and the patient has 5.6. Sometimes in this age, the gags can be normal. And the genotype analysis revealed 2 pathogenic hemisensitive variants, R383H and the P533R, confirming the diagnosis of MPS1. Here is the timeline of assessment, diagnosis, and treatment, like a summary, what we saw. Between 5 and 7 years, hip pain, recurrent respiratory infections. We need to remember that respiratory infections with otitis media started with 3 months of age, very, very, very early. Orthopedist assessment and the diagnosis of bilateral leg calvipertus with the 5 years by the orthopedist. And between 7 and 18 years, short stature, and pediatric endocrinologist assessment. And here he started to treat the short stature before with leuprolide acetate, 3.75, the same dose, and growth hormone, 0.1 Y per kilogram per day, between 14 and 18 years old. With 18 years old, short stature, moderate joint contractures, mild facial dysmorphic features, coarsening of features, scoliosis, and an umbilical hernia. Referred to metabolic disease center by treating pulmonologist, enzyme activity screening for MPS I positive, and genetic analysis confirming the diagnosis of MPS I. And he starts enzyme replacement therapy with laronidase, with the dose weekly, 0.58 milligrams per kilo per infusion, was initiated. The prognosis in patients is better in patients with attenuated phenotype because they have a bigger residual enzyme activity. Then this guy started treatment with 18 years old, and he noticed an improvement of the joints range of motion, noticed a decrease in abdominal volume confirmed with the ultrasound. He mentioned a greater disposition for daily activities. There was no progression to obstructive sleep apnea, and there was no progression of cardiac valve dysfunction. Now he is a physiotherapist, and he is the patient. We can see here some images of the patient at the time of the diagnosis, presence of kyphosis and winged scalpel, limitation of the elbow, and the limitation of the joints, the knees, as we can see here. Here is the growth, Here is the longitudinal growth for patients with attenuated MPS I from case study. Height of case study patient by age is shown by blue markers. Let me find, yes, these blue markers, okay. And shown by the blue markers with timing and duration of leuprolide acetate and the growth hormone and the laronidase, the aldurazyme. And as we can see, the patient maintain his growth curve below the third standard deviation. And after starting ERT, he still grew 5 centimeters, and at 159 centimeters at 20 years of age, between the third and the second deviation, standard deviation. The growth velocity of this patient, growth velocity by age, is shown by the blue markers, as you can see here. The patient had a peak after the initiation of the growth hormone of GH, and they have another smaller one when they started laronidase. Okay, here we have a table with the common presenting early symptoms in patients with attenuated MPS I. Growth delay is one so important, not only for MPS I, for all MPSs. Normal birth weight, but growth failure or short stature. Joint contractures, primarily in hands, claw, hand deformity, joint pain and stiffness, restrictive mobility. Carpal tunnel syndrome, recurrent hernias, umbilical and or inguinal, corneal clouding, hepatosplenomegaly, skeletal abnormalities, dysostosis multiplex, kyphosis, scoliosis, hip dysplasia, flattened vertebrae bodies, OR-shaped hibs, short thickened clavicles, bullet-shaped phalanges, dysplastic femoral heads, flattened acetabulum, coxa valga, and genovalgum deformities. Ear, nose, throat symptoms, recurrent ear infections, remember the otitis media, noisy breathing, sleep apnea, enlarged tongue, macroglossia, and the hearing loss. Heart murmur by the valve abnormalities, and surgical history of multiple hernia repairs, PE, tubes, tonsillectomy, and adenodectomy. It's important that you to alert about all symptoms may not be present in the same patient, but are usually progressive. See in figure the figure 2. One more data about early sign is the auditory screening failure at birth that is referred in some in a paper about early signs and symptoms of Hurler syndrome. This failed of the auditory test is important to as information. And usually we have one or more. Then you can have otitis media that start with 2 or 3 months of age, hepatosplenomegaly, and the corneal clouding. It's enough to think, to remember the diagnosis of mucopolysaccharidosis. Okay, it's 1 or 2 or 3 together. We can have the suspicion of MPS 1. This algorithm is interesting because it's practical for the daily activities. Patients present with a short stature or growth delay. Then you are going to a symptom checklist, joint pain and or contractures, particularly hands, carpal tunnel syndrome, corneal clouding, hepatosplenomegaly, skeletal abnormalities, ENT symptoms, heart murmur, valve abnormalities, and surgical history. Multiple hernia repairs, PE tubes, tonsillectomy, and adenodectomy. Consider MPS disorder. You can go to the urine gag test, accumulation of gags in lysosomal, results in elevated gag in urine, gags, may be qualitative or quantitative, or you can go direct to the enzyme function test. The enzyme function test is the diagnosis of mucopolysaccharidosis, measure enzyme activity required for definitive diagnosis. In 2018, we have the last MPS International meeting with patients and people that work with these diseases. And we have a testimony of a patient, and she had do 2 exomas, and they don't find the variant, the pathogenic variant, and she didn't have measured the enzyme activity. And with more than 5 years old, she got another physician, and the physician is asked for the enzyme function test. Then enzyme, it's easier to make the diagnosis of all mucopolysaccharidosis. In summary, the case presentation highlights the diagnostic journey of a patient with attenuated MPS 1 who underwent short stature follow-up for over 10 years in a pediatric endocrinologist clinic without a correct diagnosis. And it's important to note that assessment of bone age in children with growth delay is typically done with an X-ray of the left hand and wrist. Thus, pediatric endocrinologists are in an ideal situation being able to identify early phalangeal abnormalities as bullet-shaped phalanges typical of MPS. Look here, this shape. This is very typical of MPS 1. The alert for attenuated MPS diagnosis is not only for the endocrinologist, it is also for the pediatrician, rheumatologist, otorhinolaryngologist, orthopedist, cardiologist, and the others. And to finish my presentation, I'm going to show you editorial of this journal, is Rheumatology Cambridge from 2011, and they did a supplement of all papers about mucopolysaccharidosis. It's really very good. And the Dr. Giovanni Valentino Coppa is a rheumatologist, and he wrote this editorial. And why should rheumatologists be aware of the mucopolysaccharidosis? And I asked, and the other doctors, like pediatrician, family doctors, orthopedists, endocrinologists, ophthalmologists, neurologists, cardiologists, and ENT doctors. If we don't have the newborn screening for mucopolysaccharidosis in everywhere, only in some places. And it's so important, the role of these physicians to help these patients and make early diagnosis, because the prognosis of these patients is much better. The earlier is the treatment. And here is an example of a girl. It's delayed diagnosis of Shea syndrome, MPS 1 attenuated form, and the girl at 6 years of age, health, no significant medical history, stiffness of one finger since the age of 3 years, diagnosed with juvenile idiopathic arthritis and treated with steroids. In the picture B, the woman at 20 years old, initial corneal opacities, increase the joint stiffness, finger and shoulders, and diagnosed with rheumatoid arthritis by several rheumatologists and treated with steroids. This is a problem with rare diseases. When you put the stamp of the diagnosis of the patient, if many good physicians saw, or a good physician did the diagnosis, nobody changes. But the history of this patient, it's not of rheumatoid arthritis. Initial corneal opacities, increased joint stiffness. It's not from arthritis. And she was treated with steroids, keep the steroids. And the woman here with 31 years of age, dysplasia of the femoral head and acetabulum, echinovarus foot, dysostosis, multiplex, progressive cardiac dysfunction for valvular disease, treated for rheumatoid arthritis with gold salts and non-inflammatory drugs, and woman here with 53 years old, cardiac surgery, corneal clouding, because she did the corneal transplant, had the retinal degeneration, blindness, hearing loss, vertigo, finally diagnosed with MPS 1 by a neurologist expert in lysosomal storage diseases. Usually I use this case in classes that's not about mucopolysaccharidosis as an example of rare disease, of the lack of knowledge about MPS for the physicians. It's not the guilt of the physicians. Us, we don't have a discipline, at least in Brazil, of rare diseases in our graduation. And no professional health has this kind of approach during the graduation period, then it's very difficult. And we have old classification about the diseases between based on organs. And Dr. Saldobray, which is the father of inborn errors of metabolism, said that this classification, the diseases are in box, like neurology box, cardiology box, and endocrinologist box. When you have a patient like this with muc polysaccharidosis, which box is of muc polysaccharidosis? She has neurological problems, she has ENT problems, she has cardiac problems. Do you understand? We don't have this vision during the graduation period, this whole vision about the patient, not in a box, but look the patient, look the patient and hear the history, because they are telling you the diagnosis. Thank you. Now I am available for questions and answers. Oh, there is one question. Are upper airway infections, especially otitis media, early and very common only in the most severe form? No. The otitis media is frequent early symptom in all kind of MPSs, like MPS 1, 2, MPS 3, that you don't usually we don't see so much somatic manifestations, but they have otitis early, like 2-3 months of age, many times many episodes during the year. Then it's important, not only for early patients, for the attenuated patients. It's so important because it's really early, 2-3 months of age. If you have a patient with otitis media, like every month, they need to insertion the tubes and this didn't work, you need to think about MPS diagnosis. There is another one here. What are the most common findings with MPS 1 attenuated forms? We have some publications about MPS 1 registry, and we have one publication about the Shea phenotype. And the more than 80% of the patients, the attenuated patients, at the moment at diagnosis has stiffness of the distal phalanges. Distal phalanges stiff, they couldn't extend completely the fingers. It's an important one, the otitis media, the hernia that can be early like first years of life. When you saw in the severe phenotype is in the first year of life, we have hernia and otitis, all these features. But these hands, it's so important. Then you look at the hands, and after you can look the elbow and the shoulder, and probably there is another issue in these joints. Then it's important for the attenuated patients to make early diagnosis, because they have a better prognosis, because they have a residual activity of enzyme. The response is much better for this patient. Now we have another question. What are the main differences in the evolution of patients with MPS severe and the attenuated forms? Well, the patient, the severe patient, they have the complications of the disease really early in the first month of life. You are going to make the diagnosis of cardiac involvement, neurological involvement, ENT signs and symptoms during the first until the 6 months of age. 98%, 90% of the patients with Hurler syndrome has at least one or two of these classical symptoms, signs and symptoms. The attenuated patient, no. They probably are going to start with otitis very frequently, but only they are going to have really alert signs for the physician, like this guy with 5 years old with leg calcification. This is alert, and it's important because it's one disease that we don't have one etiology. And if you don't know the etiology, it's important to think about any rare diseases because we don't know rare diseases. Then it's important when you have a challenge with a patient has a problem like this, leg calcification, yet we don't know why. We need to think about one rare disease that can be any of the mucopolysaccharidosis, can be Gaucher disease, can be other rare diseases, not only mucopolysaccharidosis. Then the signs and the symptoms is going to be later. The complications is going to happen later too in the patient with attenuated phenotype. There is one question about, would you give GH to all MPS patients? No, for no MPS patients. It's not the conduct. We have some papers about, and in general, we don't have a great success with the GH therapy. We saw a good result in this case, but it's not a conduct that you extend for all patients with MPS. If you look, you can read some papers, and nobody, it's not a consensus to give GH for mucopolysaccharidosis patients. Thank you for the question. Did the girl in the presentation responded to growth hormone? Well, in the case presentation was a boy, and the boy responded. He gained some centimeters during this period. But as I said, it's not a consensus. Does the use of growth hormone increase or worse kyphosis? I think so. I think is worse for the kyphosis. Well, how do you clinically differentiate MPS 1 and mucolipidosis mild type? Well, we have some similar characteristics, but the best way to distinguish it is doing the activity, the enzyme activity measure, the enzyme activity of this patient. We have twins with mucolipidosis, and they start the investigation as mucopolysaccharidosis, and we find out the diagnosis because it's not everything from MPS. MPS is very peculiar, and they are the gingiva that we have hypertrophy, and But the best way it's really to do to measure the enzyme activity. I know Shay is autosomal recessive, but to you, Shay, more in girls? No. No, I have, well, I have more girls too, but we have more girls in every disease because we have more girls in the world. But it's not nothing was published about this. Curiosity, I have more girls with MPS 1 attenuated phenotype like Shay. I have one boy, one girl. For MPS 1 is the same, it's 50%, boys and girls. Low enzymatic levels in 2 tests with EDUA gene in heterozygosis in molecular. What is the next step? Well, you can measure the urinary gags, but if you have a low enzymatic levels below the reference value is mucopolysaccharidosis, or you can have, maybe you can check mucolipidosis too, or multiple deficiency of multiple sulfatases. You can try to, but if the enzymatic level is below the reference range, you are having one patient. And sometimes, like I told about the testimony of the girl in the MPSC international meeting of patients, and she did 2 exons, and they didn't find the 2 mutations, only on one variant, not 2. And she has mucopolysaccharidosis. The enzymatic measure, it's the most important exam for mucopolysaccharidosis, because sometimes the urinary gag is negative. If it is positive, it's okay, wonderful, can help us. But if it's negative, they not good. You couldn't exclude the diagnosis. One more. No further question. Thank you so much for the questions, for the attention, and I hope to see you in another occasion. Bye-bye.
So hello, everybody. We want to start now the case series concerning joint and bone manifestation of mucopolysaccharidosis. And first of all, there are some housekeeping points. The main points are, please do not reproduce any of these slides or contents or images or something like that. And if you want to post any question in between the presentation, you're very welcome to do so. And the rest you can read by yourself. It's a lot of text on this slide. This will get better in the coming up minutes. So starting with the main theme, just to get a short introduction to the MPSs you see over here, I will focus on mainly 2 body regions, which is the spine and the lower limb. And in all the MPS forms, you can see you have some kind of musculoskeletal involvement. Mainly, it's deformity, it's stiffness. In MPS 4, it's the instability, and all this leads over time to preterm arthritis or other degeneration problems, as well as neurological problems, mainly due to the spinal stenosis and myelopathy. You can see in nearly every form of MPS 1 to 4 and 6, we haven't seen in MPS 3 now, but maybe we just were not examining it. And on the lower limb, you see examples, clinical examples over here as well. You have mainly contractures in nearly all of the forms, also in MPS 3, maybe secondary to the CNS involvement. Of course, deformities of the lower limb, problems like hip dysplasia or femoral head necrosis, and in MPS 4, the instability is the leading phenomenon, and also leading to early joint destruction or preterm arthritis. And now I want to step into, let me see, just shortly, the upper limb. You have the same features as mentioned in the lower limb, but one feature is a little bit special, and this is the carpal tunnel syndrome, which can occur in both sides and in early childhood, and this can lead to the diagnosis of MPS 1 or 2, because in childhood, carpal tunnel syndrome is very rare, and if you see it in both sides, you can have the suspicion of MPS. And you see another feature in the hands figured out here, that there are contractures in the fingers, especially in the distal joint of the fingers. And now I want to step in two main forms, MPS 1 and MPS 2. We start up with MPS 1. And first of all, I want to show you this case. It's a female MPS 1 patient, and it's a follow-up of the hip of 17 years. And what I want to point out is that you see already a femoral head necrosis over here on both sides and in an early age of life. But if you follow up over 17 years, it's just not really progressing. What is progressing is that the cartilage, you can see over here, is nearly gone. And this is in terms of the age of the patient, preterm compared to patients without any syndrome. But you can't get this as a prognosis for the patient because it's, well, the dynamic is completely different, for example, in this patient. You see, this is MPS 1, it's a male patient without any treatment because it was not available at this year's. And you see here the hips in the beginning, they are not completely developed already, look quite fine, but there's a part of hip dysplasia. If you see, the acetabulum is shortened. And due to this, the femoral head is not round only after 3 years anymore. And over time, this is progressing. And just after 7 years, the femoral head is gone, more or less. So you have a hip dysplasia with a femoral head necrosis due to the pressure caused by the acetabulum. And this is less than half of the time, but it's the same syndrome, and the gender doesn't make any influence on this one. So if you have to judge, it's the main different feature is there's no dysplasia or nearly no dysplasia over here, and hip dysplasia over here. So this can change the outcome. The next case is a bit longer. It's MPS 1 as well. It's the first case I had in Zurich when I changed from Mainz to Zurich. And it's a young boy with MPS 1, and he was transplanted in the age of 18 months, which is just in time. And he had already this severe scoliosis, you can see over here, with a severe curve at the thoracolumbar junction, which was seen at the diagnosis. And if you have a 2-year-old with such a severe scoliosis, this can raise the suspicion of MPS as well. And over time, the scoliosis, beside the fact that the transplantation was successful with a good engraftment and good enzyme levels, the scoliosis progressed. And when I came to Zurich, this was 10 years ago, they already planned surgery for this patient. And they were really upset because I said, you have to stop the planning and first have a close look to the craniocervical junction. Because if, as you see in the former picture, I tried to get it again, that there is a progression in the lower parts of the spine, the thoracic part and the lumbar part, you have to have a close look to the upper part, which is the cervical spine as well. And what you see here is a spinal stenosis in the upper part of the cervical spine. And this had no neurological impairment at these days, but if you start to correct the scoliosis, you will produce tension over here. And this can cause tetraparesis, even though you don't touch the region at all. Therefore, we decided to decompress the stenosis. You see it mainly on the tissue over here that this procedure was made, and then take care for the scoliosis. And this part of the spine stayed more or less stable. In the last picture over here from this year, you see that the scoliosis is even worse. I will show you in the next slides, and this has an impact on the picture of the cervical spine, but the stenosis is still stable. And this is a very unfortunate, I should say, follow-up of the scoliosis. So because it was a small boy, we decided to make an instrumentarium which allows growing in this child. You can see here, and the second benefit is that you don't touch the spine. You fixate it on the ribs and on the pelvis. Unfortunately, due to the body weight of the patient, he became some kind of pressure point over here with skin irritation, and we had to remove one of the instrumentarium caused because of infection of the skin over here, and implanted after recovering from the inflammation with a shorter one. And then he had the same problem over here, and we had to explant this, and then the scoliosis you see was even getting worse, and the only solution was to take out everything. And this is, in a way, maybe a problem of the MPS as well, because the tissue is as stiff that you can't get along with your instrumentarium. And the second problem is he's still a walker, and he has less pain compared to the beginning, or is nearly pain-free. But the problem is also the hips, as I showed you in the beginning. You see, this is a dysplastic hip as well. So you have the femoral head, the hip is in a really upright position, and the acetabulum should go down to here. And this is all cartilage in this age. We know this from MRI findings. But over time, the cartilage can't stand the pressure of the femoral head against the acetabulum, and therefore the femoral head starts to rising, and there's nearly no head left in this year. And now we are discussing if it's possible and necessary to care for the hips to keep him walking, and especially pain is coming up now. So this is a typical case, and what I want to demonstrate with it is that a transplantation doesn't have a big influence on the bone, because the enzyme which is produced from the cells implanted is maybe not reaching the bone cells, but we couldn't prove this in the moment. This is another MPS 1 patient, a girl, or now it's a young lady. She was transplanted 3 times because the engraftment didn't happen really good. And in the end, she had quite good enzyme levels. But in terms of the musculoskeletal system, she took a completely different way, even though the transplantation was not as successful as in the patient I showed you before. So this is in the beginning, so she was quite old. This is not before the transplantation, but you see the typical hernia over here, the genua valga, the contraction of the elbow, a little bit of the facial features, and a little bit of spine deformity. And this was the status when she left the Kinderspital to transition to the adult hospital. There had been surgery for the hernia over here. The legs, I will show you, and the contracture were more or less stable, and she is working in a bakery. And this is her course in terms of the legs. You see there's hip dysplasia as well, and the genu valgum over here. And therefore, the orthopedic surgeon performed an osteotomy. I can see the picture, let me check, yeah. An osteotomy of the femur to get the hip dysplasia addressed, to prevent the femoral head from rising and destroying the cartilage, and a correction of the genu-valgum, which is mainly located in the tibia, as you can see here. Unfortunately, she had a problem with a compartment syndrome on the left side, because the nerve or the compartment syndrome by procedures like this are quite common, and she still suffers from her instability of the ankle. But more or less, she is a very good walker. She is working, and she had an episode of knee pain in 2011, but it recovered with non-surgical procedures. So I try to get further. And another case of MPS, and these are very old pictures, as you can see, they are not in color. This is a case from Mainz as well. And this is one of the typical cases concerning an attenuated form of MPS 1. This is a female patient, and ERT was not available for the entire childhood of the girl. But in fact, you see the face is more or less not really obvious, or not really giving us a hint to think of MPS, so MPS 1. And the hands, neither. But what you can see already is that she has a kind of thenar atrophy, which is typical for carpal tunnel syndrome. And this carpal tunnel syndrome already occurred in the age of 10. And this is typical for MPS 1, that it's carpal tunnel syndrome on both sides in the early or in childhood. And she had a procedure, a deep compression of the carpal tunnel already before the diagnosis. This is a bit dangerous, because if you don't have the diagnosis, you are not aware of the higher anesthetic risk in this patient. After 4 years, due to the ophthalmological features and the carpal tunnel syndrome, the suspicion of MPS 1 was made and confirmed. But what I want to show you is the problem of differentiating between the features of carpal tunnel syndrome and spinal stenosis. And there's a long history in this young lady from carpal tunnel syndrome and spinal stenosis. So only 5 years after the decompression, she developed pain, not only in the upper limb, but also in the lower limb. She had dystasia, and she had an aggravation of the thenar atrophy or hypertrophy, but the nerve conduction testing of the median nerve was stable. So there was no suspicion of recurrence of the carpal tunnel syndrome. And it took 1 more year to figure out that her main problem with the symptoms was not the carpal tunnel, but the cervical spinal stenosis, which was mainly made to electrophysiological testing like SSEPs. Then a deep compression from the first cervical vertebral body to the 6th one was performed in Mainz as well from the neurosurgeons. And she had about 8 years of time without any symptoms or with less symptoms. In 2003, there was the first recurrence of the spinal stenosis. You see over here the tissue aggravation due to the surgery and the spinal stenosis, which occurred again. And there was again a decompression of the spinal stenosis, but also the carpal tunnels was relapsed again in terms of pressure on the median nerve. In 2003, we had ERT available for MPS 1 and approved by the insurance, and we started ERT. And nevertheless, beside the fact that she had ERT already for 2 years, there was again carpal tunnel syndrome. So I will shorten it up because in the end, she had still problems with the median nerve, and after several surgeries, we had to stop because it was not anymore technically possible to decompress the spinal stenosis. And this is the young lady a couple of years later with the start of ERT, and still she doesn't look like an MPS patient because it's an attenuated form. But this has a big impact on hand function, which is the residuum of the carpal tunnel syndrome. Coming up to the MPS II, which is a bit different, but there are a lot of similarities. Here I show you with the follow-up of the spinal stenosis, the craniocervical junction and the upper cervical spine in MPS II. And it's nearly the same picture as I showed you in MPS I. Sometimes it's just a few segments, but it can a long distance like this one. And over time, you see it's slowly progressing. And that is the main problem, because it's slowly progressing. Sometimes the neurological features are not striking. So you don't find loss of power, you don't find dysesthesia. So you have to do MRIs every year to figure this out before myelopathy is occurring. And in MPS II, as well as in MPS I, the history can be very, very different. So there's a broad variety how it goes. These are spinal pictures of MPS II boys, all of them more or less in the same age. And you see they look completely different. And this one is the severe form in terms of definition, that the severe form of MPS II is the one with the CNS involvement. But you see it's a nice spine, it's quite straight. And this one is a more attenuated form. All of them had ERT, but you see the severe scoliosis mainly in the lumbar spine. And these are more or less in between, but again, all of them the same age, all of them have ERT, and all of them have the confirmed diagnosis of MPS II with no additional illnesses. And I like to show you a case from mine as well. It's funny, but these are the ones best documented with pictures I have. This is a male patient with MPS II. He started ERT in 2007, and you see this typical body features of MPS II. A severe contracture of the elbow, contracture of the hands, a flat spine with a hyperlordosis over here. So he can't straighten completely the hip by walking. You see, normally the leg should be there if you have complete extension of the hip, contracture of the knee, and a shortening of the achial tendon. And if you know it, the feet are typical broadened in the middle feet part. And what I want to show you in this case is the hip. So a bit focusing on the femoral head necrosis. This is the right side, this is the left side. And beside the fact that in this picture, you can't really figure out a hip dysplasia. The acetabulum is here, it is nice and bony and covers the completely femoral head. But over here, you see this one, this is the necrosis. And in the, and in the MRI, you see the difference between the two sides. This is the necrosis. There's something missing, cartilage and bone. And this patient had really high pain levels, but the problem was to figure out what causes the pain. Because if you see the X-ray of the spine, it looks really nice, it's straight up, you don't have a kind of spondylolisthesis or something, some problem over here. The vertebral bodies are more or less nicely shaped. But if you see the MRI, it was in 2004, so it was still a young adult, and you see the discs of the spine, they don't look as in a 20-something-year-old man, because if they are black, they have less water in it. So the elasticity of the discs are like in a man or a patient normally in the age of 50 or 60. And he had also a disc herniation in this part of the lumbar spine, and this can cause pain as well in the same area as the hip problem. So if you want to decide what to do, you have to be very sure what is causing the pain. Then, because if the pain is mainly due to the hip, this procedure is the one to do. if you have an adult, the best procedure to get rid of the pain is to do a hip replacement, which we did in this patient, and it was not simple because the bone had a different quality compared to normal bone, and maybe you can see that the bone marrow canal is really small, and we had really problems to get this part of the replacement into the bone. So I made it a bit short to give you the opportunity to discuss with me some questions. So if you text, or I will try to answer whatever I can. Thank you. Let me see. So the first question is, are you able to identify the musculoskeletal signs of MPS 1 from other MPSs when you first suspect? Well, yes and no. So sometimes it's not easy to get it in between MPS 1 and 2 if you have a male patient. If you have a female patient, MPS 2 is X-linked, so the suspicion will lead you more to MPS 1. Concerning MPS 4 and 6, it's a bit different. I didn't touch them in the presentation, but too much. But MPS 4 is mainly the joints are unstable, and this does look completely different. MPS 6, just from the musculoskeletal system, you will have similarities, but if you put all the systems together, so the eyes, the heart, the lung, then you will get an impression. Very problematic is it if you have the attenuated forms of MPS 1, 2, or 6, because they have not these striking features. Other questions? Okay, so the next question is, what differences does early diagnosis make for MPS, and how would a 12-month delay in diagnosis impact on musculoskeletal signs compared to starting treatment earlier? Actually, we don't know. So first of all, it depends on the MPS form. So if you have MPS 1, for example, or MPS 2 with a CNS involvement, the early diagnosis, of course, is very important for the CNS treatment. Because if you are, if the kids are older than 2 years, the chance to address the CNS is very limited. Concerning the musculoskeletal system, the data are, we don't have much data to really prove it. But what I think is, or what we have seen is that the storage in cartilage is as in all the other body cells. And what you have to take in mind is that the cartilage is the primary bone. So during fetal life, the entire skeleton is formed from cartilage, and then due to ossification, it's developing to the adult skeleton till the end of puberty. And so the mistake is already there when the child is born. And you will not reach the cartilage with your therapy because you have a lot of extracellular matrix. And what we have seen, for example, by taking the samples from cartilage in the knee, you see, even though you have therapy or transplantation, you have still storage in the cartilage cell. And this disturbs the entire architecture of these tissues. And these tissues are very dependent on the architecture of the cellular extracellular matrix to get their function and their development right. So 12-month delay for the diagnosis concerning the musculoskeletal system is actually not a long time because the system is developing very slowly, but you are already too late after birth, I think. So the And the other point is the bone, of course, is influenced by the function of all the other systems. For example, if you have CNS involvement, this will have a negative impact on the musculoskeletal problems the patient has already. So it's not easy to decide whether the treatment early or not. Concerning just the orthopedic treatment, for example, if you want to correct geniua valga, then you are dependent on growth. If you just want to do a smaller procedure, as I have shown you, so just like 8 plates or something like that, and then you have to take into account that the growth is limited in MPS, and you have to start earlier with your orthopedic treatment. And therefore, it's important to have the diagnosis earlier. So the next question is, what is the earliest carpal tunnel surgery advised? So I think the question is, when should we do it? So we do the measurement of the nerve conduction testing every year, because in children, they will not claim about numbness, they will not claim about tickling. And if you see the thinner atrophy, it's already too late because they will not recover. And if you see that the dynamic is that nerve conduction testing is getting worse and still you have no neurological symptoms, then you should do it, because then the function is still there. And the risk of the procedure of the carpal tunnel syndrome is not as big as the one in spine surgery. The next question, differentiate joint contracture from carpal tunnel syndrome. Yeah, these are 2 completely different points. So the joint contracture mainly is located in MPS 1 and 2 in the distal joint of the fingers, which is this one. And the carpal tunnel syndrome the carpal tunnel syndrome show mainly 2 features. This is the sensitivity loss of these 3.5 fingers. So the first, the second, the third, and the half of the fourth, and the hypertrophy or the loss of power of the thenar muscle. And the muscle is mainly responsible for opposing the thumb to the other fingers. So for the grip, it's very important. But carpal tunnel syndrome doesn't make contractures. Next question. Okay, so the next question is, MPS patients often deny to perform MRI if general anesthesia is required because they are afraid of possible complications due to this procedure. What would be your argument for them to do MRI in a regular or frequent way? Well, actually, I didn't feature this problem too much, but well, there are 2 points. For an MRI, you don't need a complete anesthesia with intubation. So in the early age with the kids, we do sedation, which is a bit different. So the risk rises with the terms, with the kind of anesthesia, and the risk rises with the procedure itself. So the risk is higher if you have a spine surgery, the risk is lower if you have carpal tunnel surgery, and the risk is even lower with just an anesthesia for an MRI. And I think if the parents and the patients understand that the main risk of spinal stenosis is tetraparesis, they are willing to do it, and it should be done in a center which is experienced in anesthesia in MPS. It's a bit different if you have a severe case, then sometimes you really have to discuss if you want to do an MRI, because if you are not willing to take the consequences and perform surgery, for example, decompression of the spinal canal, then you should not do MRI. So it's a very open question. The next one, joint laxity in MPS 4. Yes, there's joint laxity in MPS 4, nearly in every joint except for the elbow. This is very short. But the main problems occurring in MPS 4 are, of course, the severe genital valga, and they are relapsing after surgery. There is the severe deformity and instability of the hand and the wrist, and the instability of the feet, which are even getting worse due to the instability of the knee and the hip. So the entire chain of joints in the upper and lower limb doesn't function together very well. And of course, the spine has a lot of little joints in it to connect the vertebral bodies one to another, and you have instability over there as well. And the problem is that the instability is not only due to the joint deformity, it's also caused by the tissue around it, so the ligaments and the capsules and everything. And therefore the recurrence rate, if you try to stabilize or perform some kind of surgery, is very high, and therefore we do a lot of technical procedures in terms of ortheses, braces, etc., to keep the patient walking. Next question. Okay, I think time is over, and thank you everybody for listening. There are no further questions, and if you have questions, you are very welcome to contact me and to discuss patients. Hope all the best for you and stay healthy. Bye-bye.